to the worldwide webinar. This is season 2. This is webinar number 4, Botulinum Toxin and Bupivacaine, when and how. I hope everybody can hear me and everybody can see me. It's an amazing time. We're coming to a period of our history now where the human spirit has come together to resolve an adversity, right? Being challenged in life is inevitable. Being defeated is optional. That's what Roger Crawford said. And in that vein, I want to tell you that WSPOS rebounded with WW Connect. It is still available. And when you get it, you get 14 hours of education, and anybody who's registered by the end of December will get this free textbook, which will be published in February. So you've already registered, you're getting this textbook for free. It'll be a PDF version. It's going to be quite remarkable. I hope you enjoy it. Take this opportunity to get a textbook and 14 hours of what was a remarkable session. Going forward, we've got all these webinars. Please make note of them. These are the webinars that WSPOS, you have helped put together, and it is going to be a remarkable season 2. Remember, WSPOS, we don't charge membership fees, so if you can donate, whatever you can, any small amount, go to the website and donate. On that note, I have to tell you that today's webinar is one of the most looked forward to that I have ever done. We have an amazing range of speakers, but there's some housekeeping. We've got the Menti code. The Menti code is 105618.6. 105618.6. Take a note of that. These are the, that's the QR code. And the Menti questions will be laid out, the first 8 during the first 30 minutes, and then the last 4 during the last 20 minutes, and then we'll give you the results. So on that note, I'd like to introduce Dominique Bremont-Gignac, who is a founder member of WSPOS and on the executive bureau. She's at in Paris at the Hôpital Necker for sick children, for les enfants malades. Oh, I said that in French. I hope you're impressed, Dominique. I'm going to introduce our speakers. It gives me great pleasure to introduce Joanne Hancox. Joanne is consultant ophthalmologist at Moorfields Eye Hospital and Strabismus service director. Her main workload is complex adult strabismus. She runs a busy botulinum toxin clinic for strabismus, and she is a North Thames training program director responsible for over 40 trainees. But her favorite job, as you can see from these beautiful pictures, is being mum to her 5-year-old son. Welcome, Joanne. Thank you for taking the time this Saturday to join us. Well, I really don't know if there's enough room to tell you what this man has contributed to ophthalmology. Dr. Alan Scott, no, let me tell you, Dr. Alan Scott, everything he sent me about him is in white. Everything I have written about him is in yellow. So this is how modest he is. Alan said he's a practicing clinician interested in eye muscle problems, an interest derived from his neurosurgery residency. And he said going through school, he worked construction and later built his own house. Yes, he planned and contracted for that house that you're seeing in that picture. And then he put, I've had a few kids and I have 10 grandchildren. And there they are. What a wonderful family. Let me tell you about Dr. Alan Scott, if you don't know. He used botulinum toxin A in 1973 to treat a surgically induced strabismus in a monkey. He produced botulinum toxin type A under the trade name Oculinum, which was approved by the US FDA for strabismus patients in 1979. In 1991, Allergan purchased the right to produce botulinum toxin A and changed the name to what we know today as Botox. Alan and his colleagues developed the EMG-guided injection and then went on to describe the use of Bupivacaine to, if you like, enhance muscle action. And we're going to hear a lot about that. Dr. Alan Scott, on behalf of the pediatric ophthalmology and strabismus world, I want to give you a heartfelt thank you for your amazing contributions to our subject, things that we all take for granted today. And I want to thank you for waking up at 6 o'clock in the morning on the West Coast of America to join us. On that note, I'm going to hand you over to Dominique Bremont-Gignac, superb ophthalmologist and an important component of WSPOS. Dominique, would you like to introduce our other speakers?
Yes, of course, Ken. So first of all, I just would like to thank you and present you. I think you don't need really presentation, Ken, as you are a co-founder of WSPOS, but everybody knows you, so that's good. And sometimes you can speak French also. And so I just would like to introduce Dr. Brigitte Girard, and that's my great pleasure because she's the head of the ophthalmology department of Tenon, Saint-Antoine Hospitals in Paris. And she's also in Sorbonne University and associate professor at College of Medicine of Paris Hospitals. She's really a great friend. And I'm so happy also because to present that she has written a book about blepharospasm. But we will not talk about that. We will talk only of extraocular muscles today. And so thank you, Brigitte, to be there. So,
sorry, I'm going to advance, sorry.
If you can go further, it's also my great pleasure to introduce Dr. Rita Gama. She's in private practice in Gama Eye Center in Lisbon. Happily married with Daryl, you can see him, and passionate about her work, teaching and flamenco, so I'm really impressed. And she is the chief of the Department of Pediatric Ophthalmology and Strabismus in Hospital da Luz, Lisbon. And finally, we have also Dr. Luisa Moreira Hopker, and she's Pediatric Ophthalmology and Strabismus Fellowship at Universidad Federal de São Paulo, and fellowship at UT Southwestern, Dallas, Texas, USA. She's PhD at Universidad Federal São Paulo, and Vice President of Brazilian Society of Pediatric Ophthalmology from 2019 to 2021, so still ongoing, and ophthalmologist at Eye Hospital in Paraná in Curitiba, Brazil, where trains pediatric ophthalmology. She is so young but so experienced, and Strabismus Fellow, so elected President of Brazilian Society of Pediatric Ophthalmology. So thank you, Luisa, to be here with us.
I am just going to add, because I know this is really important. Luisa, you also did your fellowship with Dr. Mendonça in Sao Paulo, and that's going to be very relevant for your talk. So I thought I would add that. Thank you so much, everybody. Thank you. And I think, Dominique, would you like to introduce our first speaker?
Yes, I think we will just welcome Rita to begin on this WPOS webinar. So please, Rita, if you can share your screen, it will be a pleasure to listen to you.
So Dominique, Ken, and all the speakers, it's a great honor to be with you. And good morning, good afternoon, good evening to anyone who's listening to us. Welcome to our webinar. So I'll talk about botulinum toxin in childhood esotropia. And my first slide is a small tribute to the great work of Dr. Alan Scott that we've talked before. And this has changed the way we treat these conditions today. So botulinum toxin is a vacuum packed, and you can see a deposit on the bottom of the Botox bottle that we have to dilute it with saline, and this is a concentration that we usually work 5 units per 0.1 milliliter. The dosage to treat a child with esotropia depends on the children age or the deviation. So smaller children with smaller deviations will have a total of 5 units. Older children with larger deviations, 7.5. Clostridium botulinum is an anaerobic bacteria, and so the toxin in contact with the oxygen loses its activity. So if you find an air bubble inside the syringe, you should not shake it, try to dilute it, but instead slide the plunger really slowly, so the bubble moves upward and the minimal contact with the air, with the content. So we do the injection without electromyography control. And if you want to inject the medial rectus with the forceps, we rotate the globe outwards and then insert the needle. And when we want to inject, rotate the globe inwards so you can have a better volume of the muscle. 80% of the children are affected by the side effects, and the most important one are overcorrection because of the palsy that we created on medial rectus, and also palsy of the neighboring muscles like the elevator of the upper lid, creating ptosis or vertical deviation after the diffusion to the vertical recti. So the previous convergent deviation becomes exotropic with ptosis, vertical deviation, creating a very disfiguring appearance to the child, which is well tolerated by the children, but not as much for the parents. And you have to reassure them that after 4 or 6 months, all the side effects are gone and the therapeutic effects prevail. So I believe this is the critical point at this treatment. You should be very, very supportive of the parents and give them something positive so they can hold on to. And I usually say, if your child looks this way, it means that it's responding to treatment. So these are the conditions that we can treat with botulinum toxin. And I advise the injection before 5 years of age and children without associated vertical deviation, because inferior oblique overreaction or DVD are not treated with botulinum toxin. So non-commodative isotropia, we know it's a small angle deviation that doesn't change with optical correction, and cyclic isotropia, a situation where there are periods of ocular misalignment alternating with ocular alignment, as we might see in these pictures taken from the article of Dr. Oskan Group. And the single injection of botulinum toxin in these two conditions has a long-term effect. However, for sensory isotropia or isotropia associated with cerebral palsy, the long-term effects are quite unpredictable, but so is surgery, strabismus surgery. So but we have a less consecutive exotropia rate with botulinum toxin, so it's safer to use it in these situations. Probably the condition that has been more studied with botulinum toxins is infantile isotropia, this large angle deviation with alternating fixation, and we know today that large angles should be associated with an R&R surgery. We also have a study comparing a single injection of botulinum toxin between infantile isotropia and non-accommodative isotropia. And we found out that there's no differences after 1 year of injection, but the results are quite disappointing for infantile isotropia at 2 years. But if you look at it another way, that means for 1 year, these children will be quite okay. So we decided to recommend it if you're not comfortable with an early strabismus surgery on infantile isotropia, but retreatment or a surgery will have to be considered after 1 year. So when and who to retreat? If you have the therapeutic effects at 3 or 4 months, maybe you should wait 3 more months. So you decide when to retreat. I'll give you an example. If you have a deviation of 30 prism diopters and after 6 months you achieve 15 prism diopters, we're good with that. But on the contrary, if you have a difference of deviation of 10 prism diopters or more, but not enough to reach 15 prism diopters, this is a partial response. So this children is responding to treatment, you should retreat it. But on the contrary, if you have a difference of 5 prism diopters or less, means a no response, and it's a surgical situation. You can ask me, why do you have to wait 6 months if you have no response since the very beginning? Probably because we know the muscle is weakened, not enough to create a difference in the deviation, but probably you'll have an overcorrection if you have a surgery by then, because the muscle is weakened. So my final message advantages are a single injection of botulinum toxin is a first-line treatment on unaccommodative and cyclic esotropia. Expect unstable results in sensory esotropia or associated with cerebral palsy, but you will have less consecutive exotropia rates. You can associate it with RNR surgery for large angle deviations. On infantile esotropia, use botulinum toxin if you're not comfortable with an early strabismus surgery, but retreatment or surgery will have to be considered after 1 year. Explain to parents that side effects are very frequent, but are always reversible. Be sympathetic to them, and evaluate the results after treatment. And finally, this is an easy to administer treatment, safe, has no scarring effect. Don't be afraid to use it. My final recommendation, a review article of my dear friend Rosario Gomez de Leaño. I thank you for your attention, and a big hug from Lisbon.
Well, that was phenomenal. That was phenomenal. I'm just blown away. So there's lots of room for questions. We will come to that. Before I introduce Joanne, you said, I hope somebody's listening. Let me tell you where people are listening from. We have people listening right now from Argentina, Indonesia, Spain, Saudi Arabia, Israel, Tel Aviv, South Africa, Philippines, Peru, Romania, Colombia, US, Canada, Singapore, Australia, China, Brazil, Honduras, Mexico, UK, Lebanon, Nigeria, Morocco, Croatia, France, Germany, and Sweden. Woo!
Very good.
Think somebody's listening. On that note, Joanne, it gives me great pleasure to invite you to share your screen and your talk.
Okay, so I'd also like to say a big thank you for being invited on the panel, not least to be present on a panel with Alan Scott, who is the founder of botulinum toxin treatment for strabismus. Is really very special. So I'm just going to talk about the experience of running a botulinum toxin clinic at Strabismus. So it was started by John Lee in November of 1982 after he had worked with Alan Scott in the States and learned about the use of botulinum toxin for strabismus. So you can see we're heading rapidly towards our 40th birthday. So we have over 10,000 patients on our database, and with 2 clinics a week, my clinic on a Monday afternoon, Jill Adams' clinic on a Thursday afternoon.
Joanne, I'm going to interrupt. You're not sharing at the moment.
Oh.
I have your talk ready if you want me to share for you.
Me. Is that working now? It says it's saying you're screen sharing.
Okay, just
is it
not quite? It's not quite open yet. Yeah. So if you go up, go up to the beginning, and you can now you're sharing.
Good. It's good.
It's good now. Thank you.
Okay. Sorry.
No problem.
Sorry about that.
That's the beauty of live webinars.
So can you see that? So just to reiterate, that basically we were giving a combination of 2 clinics per week, over 1,700 toxin injections a year pre-COVID. My clinic alone, because the NHS was put on emergency only measures, we had to suspend around 600 patients. The toxin that we currently use is Dysport, and that's historic, and that works for us. And here's the table just showing the equivalent variations for the other forms of botulinum toxin. So the decision to perform a botulinum toxin injection is made in an adult strabismus clinic following orthoptic assessment with discussion between the doctor and the patient. If toxin injection is appropriate, they're referred into our toxin clinic. On the day of the toxin clinic, they have an orthoptic assessment, and the muscle to be injected and the consent is confirmed. They have a number of drops anesthetizing the eye with local anesthetic over 15 to 20 minutes beforehand, and then 1 drop of adrenaline just prior to the injection, with electrodes applied to the forehead. Prior to COVID, the clinic ran at over 40 patients in an afternoon with between 20 and 30 injections every week. So it's easy to see that there's absolutely no way we could have run this without the fabulous help from the orthoptists. The patient then is brought into the treatment room. There's a photograph there demonstrating the setup with the EMG leads connected to the machine. We recheck that we have the correct patient and that the correct muscle to be injected. The leads are inserted into the EMG, and we use 2.5 units of Dysport. Once we have got an accurate signal, as demonstrated on the screenshot there, we leave the injection in place for just over 30 seconds to try and reduce any spread of complications that was published from the toxin clinic previously at Moorfields, demonstrating that it really is a very safe procedure. I would just like to add that globe perforation is a risk of the procedure, although it is rare, but it's important that this is discussed with the patient beforehand. So why should you use toxin as part of your adult strabismus practice? Well, the patient may not want to have surgery or may have a considerable length of effect from the toxin. They might be medically unfit for surgery, or they may have a situation where surgery is not appropriate for them. You may also want to answer a diagnostic question, such as whether there is post-op diplopia risk, or whether the patient still retains potential for fusion when the eyes are realigned. I'd like to highlight that toxin does not replace surgery. If surgery is the most appropriate option, then obviously that is what should be discussed and continued with the patient. But I'd really like to urge everybody that this is a really useful part of your practice, and there are a lot of possibilities here where you can use toxin for your patients. Just a couple of examples is for fourth nerve palsy. A number of years ago, John Lee published that it was of no benefit injected into an overactive inferior oblique. However, once that oblique was weakened post-surgery, if there was a residual vertical deviation with diplopia, then it can be useful into the contralateral inferior rectus. Small angle squints are another area that can be helped by botulinum toxin in cases where the angle is too small and you may feel reticent in operating because of fear of overcorrection. Duane syndrome might not easily seem something that can be corrected with botulinum toxin, but it can be useful in determining whether it would be more beneficial to weaken the medial rectus surgically or do a transposition. There is a small number of patients as well where the angle is minimal in Duane syndrome and surgery could produce quite unpredictable results, who have a really good benefit from long-term repeated toxin. So in our long-term experience, the main reason for toxin is for psychosocial reasons, with only a third of patients having diplopia. Most patients have had multiple previous surgeries, and the majority of patients have no BSV and poor vision in one eye. The general trend is to an increasing gap between injections over time. It's no surprise really that the largest proportion of our patients are those with exotropias, mostly consecutive or secondary. However, whether your reason for long-term toxin is because you're exo or esotropic, the average mean deviation at presentation decreases in both groups after long-term toxin, multiple injections of over 25 to an average of 45 to 25 per group, with an increase in interval between injections over time. So, does botulinum toxin help improve quality of life for patients with strabismus? We looked at a group a few years ago with the long-term demographics shown here. Over 40% of patients managed to complete a questionnaire pre-botulinum toxin and post-botulinum toxin. This is a graph showing the results. The controls are non-strabismus controls who rate their quality of life at 84. The strabismus are new adult strabismus patients presenting to our adult motility clinics. You can see here the lowest rated quality of life group is in the botulinum toxin group when their toxin has worn off and they have no toxin, for just over 40. and it improves to not far off normal controls with just over 70 once they've had their toxin. You can see here that the lowest score pre-toxin is rated on the psychosocial score. Both scores, however, improved to similar values post-toxin. So conclusion is that the treatment of strabismus with long-term toxin is practical and valuable, and I'd really urge you, if you've not done it before, to consider it in your within your remit of your strabismus practice. The majority of patients have poor vision, with cosmesis the main reason for seeking treatment. There are many potential indications for benefit for patients, and I would urge you to consider this in patients where you think there may be no treatment option. And finally, I'm just going to leave a slide for you to read in the next few seconds, which is what one patient who had long-term toxin injections commented as part of their AS20 assessment. Thank you.
So, Joanne, thank you very much. It was very, very informative, and I'm really impressed also by your experience. And so we will go to the panel discussion. And before that, I just would like to ask to all the panel, do you remember when did you practice your first botulinum injection? I think it's a long time ago, but who would like to answer?
Well, I'm going to go first. 1994 was my first one.
2004.
Who's next? Joanne?
Yes, mine would have been around about 2010 because I was trained under John Lee and Jill Adams, and that's when I first did my toxin injections.
Brigitte?
I was also 2010 with Dr. Tomás Mendonça in Brazil.
Brigitte?
Well, my first injection was in 1990 about, but for strabismus, 1995.
Okay.
Alan?
So probably, oh, yes, of course.
Alan, when was your first injection in a human? You're muted.
You're mute. You're mute.
You have to unmute.
You have to unmute.
That's
right.
it.
I'm sorry. In 1978, which is probably before many of these beautiful ladies were born.
Not before I was born, though, unfortunately. Anyway,
Not me.
before we start the discussion, we have people who are upset that I didn't mention their country. So we also now have Portugal, Russia, Hungary, Paraguay, Cuba. Welcome, my Cuban friends. Algeria, Jakarta, Egypt, Bangladesh, and Iraq. So let's open the discussion.
Okay, so we have a question. So what kind of anesthesia do you use for children injection? For the panel.
Let's give that to Alan. Alan, do you inject children for strabismus with botulinum toxin?
My pediatric practice has diminished greatly, so I see relatively few children anymore. We're doing experimental things, and you can't do experiments on children, so that all went away, so to speak. So very few.
Okay. Brigitte, do you do children?
Not anymore. Now I'm in adult hospital, but well, when I did, we do a very light anesthesia, and it's sufficient. Yeah.
Okay. How about Joanne, Rita, Louisa?
Yeah, it has to be a small sedation, very light, because it's a very fast procedure.
Should Louisa, Joanne?
Yeah, so we've increasingly in the small children post-COVID moved towards ketamine because you don't have to intubate them, and it gets round. I mean, you can't do it in bigger children, but it gets round all these problems of aerosol generating things. So we use that increasingly in the small children. But I would say if you do that, you have to be pretty quick about it. The children, I mean, even with topical drops, they're definitely much more aware of what's going on than other forms of anesthesia. But that's working very well for us at the moment.
Yeah, I use also sevoflurane sedation under mask because it's a very fast procedure, like a minute.
Yep. So what I do is we do use a laryngeal mask, but it's very quick. But that's because I have my children at 45 degrees, because since we've been doing that, we haven't had any ptosis. So it's when they're flat and you inject that you get the ptosis. But now that and they're recovered at 45 degrees as well. So you need the laryngeal mask for that to make sure that their airway doesn't collapse. But it's quick. It's always very quick. Do you think when you counsel children or parents, the effect of anesthesia? So somebody said, there's a question that, hey, could you tell us, is it worth putting a child to sleep because of the anesthesia risk? Do you counsel parents on that? Anyone?
No, I don't counsel parents. I think for a child younger than 5 years of age, it's quite scary to watch a needle moving through your eye. So, it's out of the question doing it without general anesthesia, in my perspective.
Yeah. Good.
Yeah, I would say that as long as you're doing the toxin in children for the appropriate reasons, then I agree with Rita. They have to have general anesthesia. There isn't a way of doing that. So as long as your practice is consistent with toxin being appropriate, an appropriate treatment, then you can't get around general anesthesia.
Yeah. There are lots of questions about the technique of injection, but we're going to discuss that as people show the different techniques. I did want to ask Joanne this issue, because I've been, until this last year, I was going transatlantically and I could only get Dysport in the UK and Botox in the USA, and I had to change my doses. If I share with you your slide that shows the different doses, I'd be interested in knowing which people use which injection, if that's okay, and how they change their dose. Let me just share that with you now and see if anybody has comments. So this was the wonderful table that you showed, Joanne. Can everybody see the table?
Yes.
Yeah. So on the panel, Dominique, let me start with you and you can ask the others. Which type of botulinum toxin A do you use?
Well,
there's one B as well, which is Neuroblock, of course. But which Botox A do you use?
Well, that's very easy for France because we only have the approval for Botox. So we don't use any other because they are supposed to be the only approval for Botox and not for the others.
What about the others? Panel members?
Botox. I use Botox.
Okay. Alan, I presume you're using Botox?
Yes, I use generally Botox because it's available, but I have used all of these various things at various times, and they all work. So it's only getting the dosage correctly that's an important thing.
So, Joanne, do you want to comment about the approximate dose equivalence?
Well, so the dose equivalence in the table I've shown is what was put together by our head pharmacist at Moorfields. I think it's fair to say, if you look at the literature, people use different doses, even if they're using the same formula. And in actual fact, there isn't a direct dose response curve. So I wouldn't want to say in any way that, there is one set dose for this, whether you're using Dysport or whether you're using Botox. It's about what works for you, really. And I think one of the things that I often say to patients is that, botulinum toxin for strabismus is not like surgery where you titrate the dose given. I mean, there's a rough approximation. The more you use, the more effect you'll have. But it's not like calculating how much resect you're going to do. So we've got people with big angles that do well with this, and we've got people with small angles that do well with this. So I think it's about what works in everyone's individual practice.
Yes.
I must add something also. In France, we have 50 units for Botox also. So it's much more economic.
So, Alan, can I ask you, over the years, what is your assessment? Do you use more, when you've used Dysport, have you used more Dysport than you've used when you've used Botox?
But there's a very large community of neurological people who have used both these drugs, and they pretty much agree that it's 3 to 1. That is, 3 units of Dysport equals 1 unit of Botox or Xeomin. That's perfectly true. And I ran the Dysport titration through our standard kind of stability testing and patency testing, and it equals out the same. So it's really not too different. However, I use very different doses depending on the deviation which is there. And there is an occasional patient that you will inject that you put in 2.5 units and not much happened. And you didn't know if it's a mistake of your injection or ineffective, and then go to 5 and then to 10 units. And there are occasional individuals who are unresponsive. And that seems reasonable, just like botulinum intoxication. There's a few people that survive, and there's some people that get very sick. And so there are individual responses to this drug, like pretty much any other drug. So a single dose makes no sense.
Okay, so we will have more time for discussion, but there are some, the question board has gone crazy. So I want you to think about this, and we'll come back to this. It says, it is a quick procedure, but do you keep the needle injected some seconds after the injection to avoid spillage? So we'll come back to this, think about that. And then the other one is that anybody has any experience with the Korean, Chinese, or German brands? Remember, this is the World Society, so we've got people asking these questions. And then we will ask another one. It says, does position matter? We'll come back to that. And this one I'm going to have to look up. Does aproclonidine work in these patients? I'm not sure what that means. I think it may be about vasoconstriction, being able to see the muscle better, but we'll come back to those questions. It gives me great pleasure now to invite Brigitte to speak. Thank you so much for joining us, Brigitte. Please do share your screen.
Yeah. I'm coming.
No problem.
It's okay for you?
Yes.
Yes.
Yep. If you could just go to the presentation mode, that would be perfect. Lovely.
Is it okay? Okay.
Perfect. Thank you so much.
So, hello to everyone. Thanks a lot to Dominic to invite me to this wonderful meeting. It's a great experience for me. I'm very happy to join you. I'm very honored to speak with Alan Scott. That's our master. So I'm not really involved now in pediatrics, but in adults, and I'm pleased to show you a new device for improving botulinum toxin injection in the muscles. I'm sorry not to have any beneficial disclosure with the device. So I inject with 30 gauge needle, and this is the little device. It's electric, like an electric pump, and you can preset the volume you want to inject. The interest is you are going to inject very slowly and very continuously, so the muscle will not be in charge too quickly. So this is my 30 where are they? 30 gauge needles, and you see, I can use the German toxin. In this case, it was a squint with surgery failure. He has been under surgery twice, and they can't release this traction because the muscle, the nerve was in palsy because of surgical complication, neurosurgical complication. So they asked me to do something for this guy. So you're going to see it's a little different to take the syringe. So I get the toxin in. You cut the end of the syringe. You put in this kind of electric syringe, And this first is to make the purge, to take air off. And after you evaluate what you need. J'aurais aimé accélérer les choses. Oh yes, here it is. Great. So you just have to press. So you just have to press to make the purge. And one press is the volume you preset. So, and after, there is absolutely the same drop falling in the muscle. So you choose what you want to inject. That is, for instance, for this guy, you see, I make a little anesthesia before. That's without general anesthesia.
Non, non.
He says it's not painful at all.
Alors j'ai une petite sensation.
It was only with eye drops of oxybuprocaine. I show you again. This is to take it off. So you can see the retraction of the this little thing, and you can take off the syringe. It's very easy to use. This is the name of the trend. So another case, this is a supranuclear palsy in a complex blepharospasm people. He cannot see because of his supranuclear palsy. He couldn't put the eyes down, and he cannot walk. So we decided together to make a palsy of the superior rectus. So I make a local anesthesia with lidocaine, and after, this is with lidocaine. So that's normal injection of lidocaine to take the muscle after that. Have to take there. And after 1 minute, I inject the neurotoxin with this device. So I can grab the superior rectus and inject deeply in the muscle. I don't care what is injected, I just care where's the needle, because my finger press only once on the device. So I find it very convenient. Oops. Just what I want to show you, and thank you for your attention.
So thank you very much, Brigitte. And I'm really excited just looking at your small device, because I really want to try it and to get that for children also, because it's very interesting to have the dose, the exact dose you want just to inject, and to have just one pressure. And so this is very interesting method and for the device. And so we have a lot of questions, and so now we can go to the discussion. And we have some question that is what will be, so how many hours can botulinum toxin be stored after opening? Do you have any idea if we can use it for other people, or?
So once you've mixed it, how long can you keep it before you have to discard it?
Yes. How long? It can be used in next 24 hours, or less than that, or more than that. If you have a bottle, you open it for one patient.
Well, we did previously do so many in an afternoon that we just used to open it, mix it for the afternoon, and then do 20, 30 injections. But in the case of children, you know, if you've got one child in theatre, then it's just one child on that occasion.
I just have to clarify for the rest of the world, when in England we say theatre, we don't mean the cinema, we mean the operating room. just in case people were wondering what we were doing in a cinema with Botox. So
I would say 1 month, 1 week, but you have to keep it on the fridge.
All right. Okay. Good idea.
So in the United States, I'm only allowed to use 1 vial for 1 person. I just cannot do anything else. I'm not allowed legally to do that.
In fact, I think the same obligation in France, and to inject very, very little volume, I make a concentration higher. So there is nothing really left in the bottle. So it's one bottle, 1 patient.
Right. That's why we have also the 50 units bottle for Botox. We have also some questions about the ptosis, because we have seen that it's rare, but it occurs. And so that's interesting also to understand the mechanism. But we have a special question, because ptosis occurred the 16th day after injection in one of patient that was injected. And so do you have any idea of the mechanism? Because usually it occurs in the 48 hours, I suppose.
Let's ask that question to the panel. Has anybody seen late developing ptosis? So you do the injection, and then 3, 4, 5, even 6 days later, beyond that, a ptosis develops. Has anybody seen that?
Yes, I did. Ptosis can revealed after 6-7 days. That's usually slight ptosis, and I think it's kind of diffusion of the toxin.
But long
Louisa, you're nodding?
I have seen this also. At one time, when we were doing blepharospasm, I thought, oh, this is a very good idea. I will just put several units near the lateral canthus. So I put in 10 units. It was 10 days later that ptosis developed. That toxin went all the way around the orbit and down into the levator. So toxin can hang around and distribute itself over a lengthy period of time. Not very often, but certainly in some cases, yes.
Excellent. And so the questions are going absolutely crazy. They're very good questions. So the aproclonidine question was this. It was, if you get ptosis, can you use aproclonidine to lift the lid? Has anybody tried that? I've never tried that.
No, but it's a good idea. No?
I suppose it's Muller's muscle that
you're going to stimulate. And it works a little bit, but it only works for a few hours. And it's better than nothing for some people. It's just enough to get them binocular, perhaps, or something of that kind. And then the ptosis wears off. But ptosis can last a long time. Yeah.
So I wanted to just say that there are lots of questions about the EMG machines, the techniques, and I know, Dr. Scott, you have something about the EMG machine that we can talk about later. So we'll wait for your talk. I just thought I'd share with you some of the Menti questions. So the question was, which part of the world are you at? And as I've said to you, we've got everybody from every continent of the world. I'm not surprised that 80% of our listeners are females and 20% are males. And what do? The majority of people are pediatric ophthalmologists, about 65%. 20% are orthoptists. We have some optometrists, and we have some adult ophthalmologists who do strabismology. The average age, the majority of people are around the age of 50. That's the mean, but we have the whole age group from 30 up to I think it says over 60 there. Now, here's a good question. Have you used botulinum toxin injection for strabismus management? So there's the question worldwide. Dr. Scott, what percentage of people do you think have not ever used botulinum toxin? And I can tell you right now, the numbers are rising, but we're getting close to over 2,000 listeners.
It's been a surprise to me that people do not pick up new ideas. They certainly have learned how to do surgery very well in their training. It has a 180-year-old history, and surgery is fun to do. remunerative also. And so there are many people, I would suppose 95% of the world has not used botulinum toxin for strabismus.
Anybody else, do you think that, what's that number that have not used botulinum toxin? I think you're going to be pleasantly surprised, Dr. Scott. Well,
Yeah.
I'm going to tell you, only 40% of the world that's listening, 36% has not used botulinum toxin.
Oh, good. Good.
That's pretty phenomenal, much better than I thought. And the question is, which type of botulinum toxin do you use? And by far, the commonest is Botox at 69%. And then have you used Bupivacaine for botulinum toxin management? So that's coming on to the next talks. But what do you think? How many people have not used Bupivacaine for strabismus? I'll let Louisa answer that one. Louisa, what do you think?
I think 98%.
Well, of the people listening, only 76% have not used have not used Bupivacaine, which I think is really quite remarkable. That's really, really remarkable. We have some more time for questions and discussions. Do the panelists want to ask any questions of each other while we filter through the questions? Anybody got any questions?
Do you think Dysport is more diffusing than Botox? Make more complication? Do you think Dysport make more ptosis, for instance?
No, I don't think so. I think it's really related to the position of the patient, to be honest.
Okay.
And so it fits with what Ken says about the way that he does his children. So we see hardly any ptosis in the adults, to be perfectly honest, because we do them in a reclining chair and we have them in a much more upright position. Not even at 45 degrees, they're much higher than that. Whereas the children are very flat and we see a much higher level of ptosis. So I think it's more related to position personally than...
Has someone used neuroblock in strabismus? I think it's not a good indication for neuroblock. What do you think?
I have used it for a couple of patients who became immune to Botox. It's an unusual circumstance, but nevertheless, it works just as well as Botox does.
So there's a question about consecutive deviations. It says if somebody develops a consecutive deviation, do you patch while you wait for it to recover? Does anybody do that?
No.
You're talking about that question's related to children, I presume.
Yeah, I think that's a child-related question.
Yeah, I mean, I have to say I'm always quite pleased if they overcorrect because they are, by definition, going to come back through being straight. It's about just counseling the family and keeping them on board, and they don't seem to overcorrect for very long. I don't know what anyone else's experience is, but I don't practice them, no.
But I believe the question is a consecutive atropia means the ones who don't come back, who don't align.
No, I think the question is about the effect of the botulinum.
Overcorrection.
Yeah.
Okay.
I mean, I think that an overcorrection is good news, as Joanne says.
Yeah.
Here's a question for everybody again. We'll start with Louisa. If you have an esotropia, let's say it's 50 prism diopters, do you inject both medial rectus muscles? Let's say it's an infantile esotropia. Do you inject both medial rectus muscles or just one?
If it's a large esotropia, like 50, I inject both.
Me too.
Alan?
In children, that's fine. But in adults, you really need to leave one eye, which is uninjected. If you have both eyes now have a paralyzed muscle and they have tremendous spatial disorientation going on. So in adults, I almost never inject both eyes under any circumstance because they need to have one good eye, so to speak, so that they can walk around the world safely.
Sure.
Rita, you do for large angles for children, but not adults.
For children always bilateral, adults always unilateral.
Okay. And anybody disagree with that? That's the whole point of having panelists.
Yes, I always so any child, because it's a GA, you don't want to risk having to put them under again if it doesn't work well enough. Always do bilateral. Most adults, I do unilateral, but there are some adults when I've done one eye and it hasn't given me enough, I then might do bilateral in that case. But it's interesting, we don't tend to see like big limitations of effect of the muscles now. So I think in that case, when you're not getting a big limitation of whatever muscle you're injecting, then I think actually it's much safer to go on and inject the other side, because you've still got relatively normal motility.
Okay.
Right.
I think we're going to move on.
Right.
So I'm going to introduce, we'll come back. There are so many questions.
Yeah,
I'm a
that's
bit
good.
overwhelmed, right, Dominique? But we're going to, so I'm now going to introduce Louisa, I believe. Louisa, if you'd like to share your screen, we look forward to your talk.
One second. Are you?
Perfect, perfect.
All right. Well, thank you very much for WSPOS for the invitation to talk among such great ophthalmologists and a subject that I like so much. So I'll be talking on Bupivacaine mechanism and also show my technique of injection in the extraocular muscle. I have no disclosures to make. And so let's start talking about how two pharmacologic agents act in the extraocular muscle. We know that botulinum toxin weakens the muscle, while bupivacaine strengthens the muscle. So bupivacaine is an anesthetic used for many years in ophthalmology for retrobulbar and peribulbar anesthesia. But in the late 80s, several reports of diplopia came out, especially after cataract surgery, that were secondary to deviation, such as hyper or hypotropia of the operated eye. And the misalignment of those patients were due to overaction or contracture of an accidentally injected muscle. Because of the path of the needle during the anesthesia, as we can see in this figure of an MRI superimposed with a needle, inferior rectus was the most affected muscle. Here we can see a patient with the right hypotropia after a cataract surgery with retrobulbar anesthesia, and an enlargement in the right inferior rectus showed in the CT of the same patient. So then in 2007, Dr. Alan Scott published the first case report of bupivacaine injection to treat strabismus, showing us a correction of 10 prism diopters in a patient with esotropia after an injection of bupivacaine in the lateral rectus. And that changed the way we all look at this drug. It came from a problem of the cataract surgeons to a possible solution for strabismus. And so how does bupivacaine affect the muscle and the alignment? There's an initial necrosis, which clinically is translated by aparesis. The eye will then deviate in the opposite direction of the injected muscle. Then you have the regeneration process with a new and stronger muscle, and the deviation will happen towards the affected muscle. So muscle is rebuilt shorter and stronger, especially if you inject botulinum toxin in the antagonist, because it will prevent stretching of the injected muscle. So let it break it down, and let's see what happens with the histology of the fiber after bupivacaine injection. There's damage in the fiber with necrosis, and inflammatory cells will mediate the activation of satellite cells and perform the regeneration process that will proliferate and form a new fiber. So here in this figure, we can see a superior rectus of a rabbit 7 days after injection with necrotic fibers and inflammatory reaction in the arrow, and new fibers already in the regeneration and the arrowhead. And here in this other figure, we can see the muscle 30 days after the injection, showing new fibers with almost normal appearance. And what characteristics does this new fiber has? It has an initial increase of the area of the fiber seen on histology, and an increase in the extraocular muscle area and volume seen on MRI, as in this figure. So here is a right lateral injected muscle with increased area. And both are followed by normalization after a certain period of time. There's no fibrosis formation, as we see in these pictures and of a control muscle and a muscle after 60 days of the injection with the same amount of collagen. There's also a temporary increase in the proportion of myosin type 1, which may play a role in the increase of the force of the muscle. There's a greater effect on the global layer of the muscle, where there's more singly inverted fibers. And at the end, the new fiber has increased tension, increased contractile strength and elastic stiffness, and a shorter length. And those changes are not achievable by surgery. The change in alignment is long-lasting, which is different from botulinum toxin. And the clinical studies show us that that can last up to 5 years. And how about the dose response? We know that 1 to 2 mLs of 1.5 to 2.5% of bupivacaine can correct among 6 to 12 prism diopters. And we know that if we increase the volume at the same concentration and associate botulinum toxin and the antagonist, we can get a greater correction between 10 to 20 prism diopters. And how do we inject bupivacaine? We have to use EMG in adults with topical anesthesia. We locate the muscle with the needle of the EMG, and we have to inject in the posterior third of the muscle because bupivacaine doesn't spread as well as botulinum toxin. And then we have to look for immediate paralysis after the bupivacaine injection. For example, this patient in the lateral rectus, we see that there's a large limitation in abduction after the injection. And how I inject botulinum toxin? I use Mendonça's forceps that allows the transconjunctival injection in adults under topical anesthesia and children, as we already discussed, with sevoflurane sedation. And I'm going to show a video here of the injection. This is a kid with a 30 PD esotropia. And so you can see how you can easily hold the medial rectus with the forceps and perform the injection of botulinum toxin, which lasts less than a minute, and you are done. So what our take-home messages are, for bupivacaine, we have initial necrosis followed by regeneration and a new muscle formation. There's temporary increase in the area of the fiber and the muscle. There's no fibrosis formation, and there's this increased strength of the muscle, of the new fiber. The injection technique of bupivacaine with EMG concentrations 1.5% and up, the volume between 1 and 3 mLs, and for botulinum toxin, I use Mendonça's forceps. So I'd like to thank to this great ophthalmologist and also for the opportunity of being here. And here I have no commercial interest, but this is where you can find the Mendonça's forceps. Thank you very much.
Thank you very much, Luisa. It's very informative, of course. And before just beginning the discussion with the panel, I just have a question. Bupivacaine is the only anesthetic that has this action, or is it also ropivacaine also?
Early studies in rats and rabbits show that bupivacaine has a greater myotoxicity than ropivacaine and other anesthetics such as lidocaine also.
Okay, very good. So we have a lot of questions.
So I'm just going to say that from the Menti questions, there are only 6% of people who have voted who have used bupivacaine and botulinum toxin in the same patient to try and correct the strabismus. So I think that's quite interesting. I think, Dominique, for the sake of time, we need to invite, could you invite Dr. Scott? And then we can then we have a lot of time for discussion thereafter.
Then you are allowed to share your screen, and thank you for going on.
Is that I'm up?
We can hear you, but we don't have already your screen.
Okay.
Well, while Alan is sharing, there you go. Fantastic. Well done. Thank you.
Thank you.
Well, good morning, everybody. Again, at least it's morning where I am, and happy to see all your happy faces. Botox has been around now for over 40 years, and it's very good because there are a lot of strabismus cases which are due to overaction of muscles, and Botox reduces those. Botox pretty much depends on fusion afterwards, though, for its stability, because the mechanics of the effect of Botox, that is paralyzing the muscle and then letting it recover, does not allow the antagonist muscle to change enough to really hold the eye in very many cases. So strengthening the antagonist would be a useful idea. And out of the about 250 cases that we've done, I've selected just this topic because it shows some effect in cases that could not easily be done in other ways. These are eye muscle injections for people who have had unsuccessful surgical repairs, 1.8 on the average. And one of the things about this that Louisa mentioned is that the effect is very permanent. And indeed, we see a set of cases here with long-term follow-up and great stability over time. Not perfect, but very good and probably equal to surgery or close to it. If we started off in 2006, as you see on the left side of this graph, we found that we corrected about half the deviation, but with time, we've increased the dose of bupivacaine, and therefore we've increased the correction percentage. So we correct about 75% of the deviation, which is present. And these are some numbers that are useful to have: 20 or 30 milligrams for small deviations, 30 to 60 milligrams, and 40 to 90, because the amount of drug, as long as the volume is adequate, the amount in milligrams is probably what really counts. We see on the other side that we use a little bit of botulinum toxin, not very much, but occasionally large doses. And if you want to use anesthetic concentrations, which are available everywhere in the world, you get a remarkable correction average, around 7 prism diopters, and there are many additional cases to these which have been reported. So this is the use of bupivacaine in anesthetic concentrations. If you want to get more concentrated bupivacaine, you need to go to your pharmacy in the hospital or compounding pharmacies. It's not terribly expensive to make up, much cheaper, of course, than Botox. Here's one of the pharmacies that makes it, O'Brien, for everywhere in the US and maybe elsewhere, and Koshland, which makes it for California. I'll put this on later for those few who might want to reference this. So back to our cases, we had 44 cases, 24 prism diopters, and I wish my cursor worked here, but it doesn't seem to want to move on these slides. So you see the initial misalignment was around 24 on average, some of them much bigger. The number of injections is 1.2, so out of 50 patients, there's 10 of them that needed additional injections, and the amount is over here, 59 milligrams. Very important to realize that using small amounts doesn't create much effect. We can create then about 73% of the correction of the initial deviation, as you see an absolute correction down here. 17 prism diopters, 73%, and about 60% of those cases will fall into the 10 prism diopter or less alignment category, which is, quote, success. If we add a few patients, there's a large number of people who have been operated upon once or 2 or 3 times that have 10 prism diopter deviations that bother them or give diplopia, and they want to have them corrected. And if we add those in, then the amount of correction percentage goes up, of course, and about 70%. So here's a case. This gentleman had a bimedial rectus recession, and then he had 3 subsequent operations to bring the eye backward. None of them worked, and here he is, as you see, with an exotropic right eye. We're injecting now Botox into the lateral rectus muscle. And do we need an EMG to do this? Well, for eye muscles that have never been operated upon, you pretty much know where the muscle is, and people very successfully inject without EMG. But if you are doing this case, you see that 1.5 inch needle is all the way into the back of the orbit before it found the lateral rectus muscle. And I don't think that you can be adequately successful without EMG to find the muscle. So that much is injected here. These needles are rather expensive, so we wash it out. Attach the Bupivacaine syringe, as you see in the right side. This is actually a video, but I'm not going to do that. And we see that whereas the medial rectus also, you expect to see it way, way back there. They never did advance it. And so there's the evolution of alignment is that both these muscles are slightly weakened. The lateral by Botox, the medial by Bupivacaine, and we see some inflammation in that right eye in the interior area where Bupivacaine went. And but after a couple of weeks, the eye remains aligned, and at 3 weeks it's aligned, and the evolution of the medial rectus change after Bupivacaine is interesting. First, of course, it's paralyzed because Bupivacaine does that, but then it damages the muscle. But in a couple of weeks, as you see in the medial, the next frame, the eye is starting to adduct, and in 3 weeks, it's getting better. The lateral rectus initially doesn't respond, a little slow in this case for some reason, to Botox, but at 2 weeks, you can see that right eye does not abduct. But in 3 weeks, the Botox is starting to wear off. And 6 months later, why the eye can abduct and the eye can adduct, and the alignment is good. Interesting that his doctor saw him a couple of years later. He's still very straight, about 10 esotropic for near. That is to say, we over-corrected him by these injections slightly. For near, he's ortho and fusing after all these years. So a similar case, but more serious, bimedial injection, and made exotropic and operated on a couple of times. And we can see in these left side frames that the left eye does not adduct very well. But after Bupivacaine to the left medial rectus, and again, notice that it's slightly red from the reaction to the Bupivacaine, and some Botox to the lateral, the eye is in good alignment. And the medial rectus was found 25 millimeters behind the eye. It would have been a tough surgery to do yet again an operation. And here she is a couple of years later, and we've seen her a number of years later, and she's quite stable. This gentleman had a cataract surgery. He then had 3 retinal operations. He then had 3 strabismus operations. On the third one, however, the sclera had been on the medial side absorbed, and so they closed up and aborted the operation because it was too dangerous. So we injected, of course, Bupivacaine in the lateral rectus. Botox in the medial rectus, and here he is a couple of months later. Please note that the bupivacaine amount is quite considerable, and it's important if you want to rebuild the muscle to use a large amount. And he's seen a year or so later, he adducts adequately, What happens with this situation? Multiple glaucoma filters, and he has a couple of valves into his exo as well as vertical. Well, you could operate on one eye for the horizontal and one for the vertical, but then it's much easier to put Botox in a couple of muscles and bupivacaine in another couple of muscles, and you can pull that eye up into line. So there's a very straightforward case. She's secondary exo, 40 exo after bimedial recession, and here she is after bupivacaine and Botox. She looks terrific. Now, look here, however, at the adduction. These are on the right side panel of this slide, and I don't know if you can see them, but they're on this side. The eye does not adduct, it does not adduct, and it does not adduct at all. But after injection, it adducts, and it adducts, and it adducts quite fully. So this muscle has been quite substantially changed. And to show that effect, here's a lady whose 32 millimeter long eye has undergone stretching of the muscles and displacement of the eye, and she has this classic esotropia and hypertropia. And that shows, of course, the lateral rectus on this right eye, and you'll see on the slide, is displaced. And after a couple of injections there, actually we slightly overcorrected her with a slight second one injection, but she said, oh, it looks terrific, and should never look so good at her. Now look at the muscle itself, it's hugely increased. So this enlarged, this big muscle now can hold the eye, unlike the surgical shortening of a thin muscle when we used to do recess-resect for these kinds of cases. So this is susceptible to Yokoyama surgery, of course, or similar things, similar surgery, but injection, it worked very well indeed. And so a year later, she was fine. Several years later, she was straight. And I saw her just recently, and she has slightly turned back in, and MRI shows that muscle to be slightly thinner, but she's only 80 so, and she likes it this way. So finally, one final case, somebody with blood flow spasm, and she has bilateral ptosis. And it's an easy operation to open the eyelid and tighten that muscle, but she didn't want to have surgery. So we injected the right eye at this date, and you look at the date, you'll see it's 12/8/10. And 2 days later, the eye is swollen because bupivacaine damaged the levator muscle. But a couple of days later, that's gone away, and the eye is starting to open, and it progressively opens. And here we are a month later, and that eye is actually open slightly more than the other eye. So what happens, she sent us a photo, it's not very clear, but a couple of years, almost 3 years later, you can see that that eye is more open than the other eye. Once again, here are some numbers to look at on utilizing injections, 20, 30 milligrams, 60, 90, and compounding pharmacies in case somebody wants to click a picture of this. And here's one of the EMG units. I noticed that Louisa uses this Clavis unit. It's very good for EMG. And I recommend also a unit that we have made, which does muscle stimulation for people who are under anesthesia. That's a completely new, separate issue. But it does muscle stimulation, which the Clavis unit doesn't effectively do. So bupivacaine, it adds quite a little bit to our armamentarium to treat cases of strabismus. Surgery will certainly remain the main thing. Botox will be the main injection thing, but bupivacaine will supplant Botox in many cases because it adds strength and stability. And also it's all over within about a month's time, whereas very often Botox effects straggle on for 2 or 3 months afterward. Thank you.
What an amazing tour de force. If Dr. Scott, if you could stop sharing for a minute, we can open the questions up. I have learned so much today. This is just extraordinary. The questions are going wild. Let's stick to bupivacaine. The question is have people used bupivacaine in children?
No. The answer is no. We happen to have a director of our research hospital committee who has made the decision, a sort of using bupivacaine in children throughout much of Northern California hospitals, actually, as it turns out. So we've been prevented from doing this. The University of California, UCSF, one of my fellows is now working up there, and soon they will be adding this. So there's no reason to think it shouldn't work. Many of us, of course, use a little bit of bupivacaine at the end of strabismus operations just for anesthetic purposes to wash out the wound area for a while. So it's been 40 years since bupivacaine came around, so it's a perfectly safe drug. It just needs to be used carefully. But using strabismus, the answer is no.
Okay, so has anybody used it in children?
No.
Okay, so let me bring up a topic that's really close to me. I see a lot of children with developmental delay, what I would call the special needs children, and they often have exotropia. And when I first got to the US, many of these children had had multiple operations and had come to me for another opinion. I really don't think that until these children have had their orbital growth and they're teenagers, that we should be operating on them because the recurrence rate is so high. I think botulinum toxin, and maybe this is a case where we could make a case for the IRB that bupivacaine would be a combined therapy that might be helpful. But let's just talk about botulinum toxin. How many of the panel, Dominique, I'm going to start with you. Do you use botulinum toxin for children with exotropia or strabismus and developmental delay?
I do that, but not usually, because usually I perform more surgery, regular surgery.
So my experience is that you get lots of recurrences. What does the panel think? Let's just go around. Let's start with Brigitte and then Joanne, Rita, Louisa, and then we'll finish with Alan.
With recurrences, and that's why I just go further to regular surgery. But maybe the panel can say something else, right? If
you should use botulinum toxin. I couldn't agree more with you, because it's quite unpredictable what the results, and if it doesn't work, it can always reverse somehow. So it's safer. I would use, yes. And we know on lateral rectus doesn't work as well as in medial rectus. That's why probably you were asking about bupivacaine. But even though it has a transitory alignment, that's better than doing a surgery and have a recurrence. So I couldn't agree more.
Other panelists? Just jump in.
I would say I wouldn't use botulinum toxin as my primary measure. I mean, I think there's a balance. So I agree, a lot of these XTs you do see recurrence, but some you don't. So my primary option would be to go to surgery. But obviously, if you then get early recurrence, you can use botulinum toxin to treat that. I mean, the other thing you've got to remember is that if you're using botulinum toxin, depending on how long it lasts for, they're having to have a general anaesthetic every time that they have it done. which if you're doing that a lot is not necessarily the best thing. So that's one of the reasons that I tend to consider surgery first of all, but with other recurrences may then go on to do toxin.
Well, this is what, to Alan's point, I mean, this may be a group of children where we could get genuine IRB and say, we want to use Bupivacaine in the medial rectus and we want to use Botox in the lateral rectus, or Botulinum Toxin. I mean, because you're right, the problem is the recurrence. But my worry is when I do surgery, I've seen children who get a recurrence. I mean, there have been 2 papers on this, and the average number of surgeries that these children get by the time they're 17 are between 5 and 7 in the papers that have been published. So we're going to move on to questions. What about the use of botulinum toxin in thyroid disease? You guys have got to jump in, otherwise I pick on you. Louisa?
I don't use very often for thyroid. I rather wait for the time that they are stable and operate on them.
Alan?
I use botulinum toxin a lot in thyroid eye disease, especially early cases. The eye is out of line. It's a little more than prisms can handle for the patient, and so I inject the inferior rectus typically. In cases where the alignment and the eye is really down 40, 50 prisms on occasion, you have to go through the eyelid rather than trying to inject through the conjunctiva through the inferior fornix. But I should have shown you perhaps one case that was 40 hypotropic, injected on 2 occasions, and wound up 6 prism diopters hypotropic that needed a 5 millimeter inferior rectus recession, a completely different surgical outcome than would have been present or in ordinary cases. Yes, I don't know what Tepezza is going to do for us. Maybe it's going to replace this, but at least at the moment, this is still a useful treatment. Yes.
I will get severely berated by David Granite if I don't tell you that he wrote a very good paper. That's his words on my phone, not mine, about the use of botulinum toxin in thyroid eye disease. I mean, when I was doing adults, when I first got to the US, I found it to be really helpful. What about Joanne and Rita and Brigitte and Dominique?
So I find that it works well for some of the small deviations initially. I would completely agree with that. And I think it also works well for some of the small residual deviations post-surgery. So the big deviations that you've operated on and you've got them really as good as you possibly can get them with surgery, but they're still not as good as they might be. I've got quite a significant group of patients like that, where botulinum toxin just helps them get single. I would say just mainly the technique that I was taught initially, which was by John Lear. I tend to do all my inferior rectus injections through the lid, but that's just the way I prefer doing it. I totally appreciate that doing it around the globe works just as well in a lot of cases.
Can I ask what dose do you use for the inferior rectus when you're injecting?
2.5 units.
What dose?
Dysport.
Dysport, yes. Does it use for standard dose?
Sorry, say that again.
How much Dysport do you inject into the inferior rectus muscle when you're injecting for thyroid eye disease?
Yeah, 2.5 units usually.
Okay, but I would want to comment that we use often as much as 10 units, and we often have to inject in 2 places in the muscle because it's hugely enlarged and to get a big enough effect. And I think others have also found this to be true. So it really requires a lot of toxin.
I wonder if the slight difference might be is that you and other people who inject large amounts of toxin may be doing it for bigger deviations possibly, whereas a lot of the thyroid patients that I tend to inject it in tend to have had large amounts of surgery and just have a small deviation that might That might be the difference. I don't know.
Sure, for a small deviation, that's perfectly right. But for a great big muscle and a great big deviation, well, then I think one needs to at least consider enlarging the dosage.
No, I would completely agree with that.
So, Alan, I think when you said 10 international units, you're talking tox, right?
Talk about Detox or Xeomin, yes.
Yeah. So, look, I think, so I want to tell you, I cannot remember seeing so many questions coming thick and fast. And I apologize to the audience members whose questions have not been answered. But what we will do is we'll send them to our panelists and we'll get some answers back. We'll create a PDF a file for you guys to be able to get. We're actually out of time, but we're going to run over. I'm taking the executive decision to run over a couple of minutes. I'm going to go around the panel. If you had a pearl to give, Alan, you're going to be last, so get your pearl ready. What would you give? A pearl. Louisa?
I would say use Bupivacaine for small deviations. I think it works greatly, and I think we still have much to study on that dose response, but small deviations, especially under 10, I think it's great.
Brigitte?
Be precise, stay in the muscle, not to make any diffusion. So the best way not to move, and I think it's a good thing not to take off the needle too quick, so the toxin can stay in the muscle and not leak.
Okay, Joanne?
I would say we all know there's a significant proportion of patients with small residual deviations that are terribly bothered by them and often get overlooked. And I would really encourage people to use botulinum toxin for that. Although there is the risk of overcorrection, with small doses, they very rarely overcorrect. And actually, they're some of the happiest patients, even though they've got the smallest deviations.
Rita, that was great. Rita?
Don't be afraid to use it, because it's a safe procedure, and the more you use it, the more you will want to use it. So you become very comfortable using botulinum toxin. Don't worry.
Dominique?
I think really for large angle deviation in very early strabismus, it can change really the visual development of the child. So even in very young children, it's a very good indication to my knowledge.
Thank you. Alan, before I come to you, I'm just going to give you some Menti results. So initially, 69% said they were going to use, that they'd used botulinum toxin in strabismus. Now, 93% said, having listened to this audio, to the panelists, they're going to use botulinum toxin. Initially, 16% said that they had used bupivacaine in strabismus, and now 25% say they will use it. 67% say they are not sure, but we didn't have that 67% being unsure previously. They were saying no. 6% said they used bupivacaine and Botox together. That was 6%. That has gone up to 20%. And 80% are now not sure. And then we asked them, I think this is very telling. We said, what, according to you, was the best part of the webinar? And this is what we call a cloud. And the biggest word is discussion, followed by experience, followed by innovation, worldwide, new knowledge. And then we have two big ones, which say Alan Scott, Scott. So on that note, Alan, I have one question that is a personal question, and the other one is your pearl. I mean, you have so many pearls. Alan, what drove you back in the 70s to think that botulinum toxin, which was this lethal thing, could be used? What was that spark of genius? Can you please let us all have some?
Actually, what we had been doing was paralyzing muscles with xylocaine to see what happens to the extraocular forces, because we were studying forces and innervations and things like that. And it occurred to me anyway, that, hey, let's find something, since we now had developed electrodes to inject muscles, let's find some stuff to try. And we tried a number of things. And botulinum toxin actually came up fairly early, but it was way down at the bottom of the list. It was too crazy. But eventually we gave it a shot. There's a couple of publications that showed that it could be injected in chicks to interfere with development of the muscular system so that it could be a localized effect. And I think that was a critical aspect of it. So, you know, all these things come from the development of people who came before us, and similar same for this one.
Phenomenal. And yes, what is there a pearl that you'd like to leave us? I mean, everything you've said, everything everybody has said today has been phenomenal. Is there a pearl you'd like to leave us with before I do the wrap up?
There, I have too many ideas to choose one.
Oh, okay, but how about if you're right now, there's an alien that comes down and says, Alan Scott, we understand that you have changed the way people look at strabismus, and we want to take one message back to our own world. What would that message be? That's because they don't speak English very well.
Well, that
you've got too much to tell us.
I think I would just say look ahead, because there will be new things coming along all the time, and you should be paying attention to the literature and what happens. So there's new operations, there's new injections, there's certainly going to be new medicines to inject in the eye muscles that'll work better. There's a large number of people that are interested in making muscles work stronger. Orthopedists and certainly the meat industry is very strongly involved in this. And so there's lots of people who care about muscle function and so on. So pay attention, I guess, is the right word.
Thank you so much. Look, I'm going to wrap up. I can't tell you how amazing this session has been. I am absolutely awestruck by all of you, such amazing things that you do. So to wrap up, remember, registration for WW Connect is still available. It's cheap. It's cheap. And you get a book, and you get all of this content. So please think about that. These are our webinars. They're coming up thick and fast. We got the global grand rounds, which we've got a little advert about in a second. I have to say thank you to everybody. Please remember, free membership, WSPOS. Remember the international listserv. David Granite runs that. If you write to him, he'll help you get on. The web page, the Facebook page, you guys are all amazing. Remember, if you want a certificate for attendance of the webinar, that's who you email. And they will get one for you. Remember, I think this is so important. We're together apart all over our world at the moment. And I want to thank everybody. Be safe, be healthy. Thank you, Dara McCafferty and Akilacharya, as always, for administrating the website and the webinars. And Todd for supporting us. You're amazing. Now, season 2, webinar number 5 is the Global Grand Rounds. That's moderated by Dr. Alki Liassis, head of the electrophysiology lab at Children's Hospital of Pittsburgh and Department of Ophthalmology, Pittsburgh. Dr. Lotte Wallander, sorry, I made an error, a spelling error there. Dr. Wallander is from Denmark. It remains for me just to say, and Dominique, perhaps you'd like to say a thank you for all the speakers, and then I'll play the last video.
Yeah, thank you very much for all, because it was very informative and very fruitful. And so all of you, thank you for listening and interacting. And so have a nice time and take care.
So we've got one video to show you, which is from the Connectivity Bureau, but I have to read this out. This has come from on the YouTube channel. It says, awesome. Please thank Dr. Alan Scott on behalf of all the specialists and their patients he has helped worldwide. Thank you so much. Alan, I think all of us will agree that your contribution is immeasurable, but I want to thank everybody on the panel for taking up your contribution and spreading that word. So here is a short video.
Hi everyone, we have global grand rounds on the 12th of December. We have one strabismus, one non-strabismus case. Be there, this is something you don't want to miss.
Both these cases will be discussed by panelists around the world. They will discuss the most clinical aspects and surgical aspects of these cases.
I'll be presenting a case of aniridia and hopefully generate discussion about things we don't normally talk about.
One of the biggest challenges for me to treat aniridia is what prescription to give to the child. Is it accurate or not in the clinic exam? You'll get to know how do we measure prescription glasses for a child with aniridia in this grand rounds.
Also, in children with aniridia, sometimes we forget that we need to give them lubricants. What kind of lubricants do we need to give to children with aniridia? This should be interesting to be discussed.
In addition, do contact lenses have a role in the treatment of aniridia? And what can we, or how should we prescribe them, if so?
In the anti-elevation syndrome, how can we prevent it and how we can resolve it?
Anti-elevation syndrome. It seems like most of us have it, most of us see it, but we never talk about it. How do we prevent it?
You're absolutely right. And that's why you should all be there. December the 12th, Global Grand Rounds. We're going to talk about the things they never talk about. Be there. You're all there. Okay, on that note, I want to say thank you very much. Namaste, everybody. God bless you. Everybody, you've done an amazing job. Thank you very much for making this an extremely special webinar. Take care. Bye-bye.
Thank you.
Bye. Bye-bye.
Bye.
Thank you very much.